It's my great pleasure to focus you a little bit maybe on the potential fourth vaccination on vulnerable patients. I will talk or focus my talk on vaccinations on autoimmune patients and certain patients under very strong immunosuppression. When we look into the challenge here, which is actually a dilemma, and I will mainly focus on risk assessment and risk mitigation in these patients, we have the availability since about 1 year for the new mRNA vaccines and the adapted vector vaccines. And we see our patients with certain underlying diseases, immune diseases. I'm not only focusing on rheumatological or in particular inflammatory rheumatic disease, but also on patients with severe kidney impairment, kidney transplant patients, as well as dialysis patients. And we have a very important third variable or confounding factor here, that is the underlying treatment, where we know that the underlying disease already leads to being immunocompromised. But this in addition, and I'm trying to give you a little bit more insight that we learned a lot here during the infection itself, but also during the pandemic. But I will mainly focus on the outcome of the infections. And here we have the possibility, and I think this is a huge possibility on also connecting some of our immunological thinking with classical outcome measures, not only in terms of the safety of the vaccinations, disease flares, and control of the disease, but also in terms of the efficacy of the vaccination, because we are able on a large scale to look for breakthrough infections and also capturing death in those patients, which is very, let's say, almost impossible to do on preclinical grounds. So let's start with some outcome observations. The EULA, which started a registry for vaccinated patients with rheumatic diseases, comprising about 30 countries. And here we have an intermediate data available for more than 5,000 patients. 90% of those are suffering from inflammatory rheumatic diseases, and we have about 10% with non-inflammatory osteoarthritis and so on, which serve as a kind of control population. The very important point was here, and I think this is really consistent with our own observations and experiences, flares have only been observed up in vaccination in about 4.4% of the cases in total. Only 0.6% have been reported to be severe, and only 1.5% required adaptation of the medication, so an escalation of the therapy. And I would think that this is in the range what we usually would also expect in daily clinical practice outside of vaccinations. The adverse events in terms of their rate, severity, distribution, and so on was quite comparable with controls. That's also a very important message. So safety, and 70% have been vaccinated with mRNA vaccines, 17% with AstraZeneca, so 70% with BioNTech and 8% with Moderna. So reflecting overall what even also in our population was happening. A very interesting report from a larger registry coming out of the US. I think this illustrates the problem in terms of the outcome and breakthrough infections. This is a large US N3C registry. More than 600,000 fully vaccinated patients have been included here, and they have reported about 23,000 infections. The overall incident rate ratio was 5 per 1,000 patient months. So it's pretty unusual, but it's important. The denominator is 1,000 patient months. Before the Delta period, it was 2.3, and afterwards 7.3 per 1,000 patient months in the Delta period. But the most important observation was here, the cumulative breakthrough infections here per 1,000 persons. Absolute in the lead with an adjusted incident rate ratio of 2.16 of patients after solid organ transplantation, followed by HIV. And I was really impressed to see rheumatoid arthritis patients on third place with 1.2 per 1,000 persons. And here you see the gray line. This is the reference population without any immune dysfunction, no treatment, nothing, kind of controlled population. So this already should open a little bit the scene in terms of what the challenges in those patients are. But coming back to the EULAR data that are available in terms of the breakthrough infections, we have one situation where patients after COVID-19 infection have been collected or captured. This is more than 9,000 patients. And again, from the COVAX vaccination registry, about 4,400 patients altogether. And I think this is somehow semi-reassuring. Only 38 infections, breakthrough infections running below 1% have been reported. 26% of them have been fully vaccinated. And as you can see here, the majority, 3/4, 74% were only partially vaccinated. 3 patients died. This is about 8% out of the 38 infections, which is a high number. But those 3 patients are very instructive. And I will go into more detail on a broader scale in the subsequent slides. All of them above the age of 70 with different diseases. Maybe it's not so important to go into details, but one patient was under mycophenolate and prednisolone 10 milligram per day, which is already considered as a higher risk for acquiring infections. The other patient here was after an anti-CD20 B-cell depletion therapy, rituximab. We heard this already by Michael Lohoff this morning. This was already half year after the last infusion, when I would have assumed the B cells have already been repopulated. But we know that rituximab and MMF per se are higher risk medications for contracting the infection. So when I was thinking what I should discuss here, I went back, and actually Andreas, together with me, we wrote some years ago a review on antibodies and B-cell memory in viral immunity, not experiencing that we will be ever entering in an area of a pandemia. And we made a kind of distinction. Short-term protection provided by B cells is by not producing natural antibodies. I call this the first emotion by the immune system to really provide an let's say, directed protection. But then, and you heard this already this morning, and you may forgive me, but I tried to make this as simple as possible. It's very important that we have proper, upon recognition of the antigen, co-stimulation or interaction between T cells and B cells. And this does not only lead from naive B cells into memory and effector T cells and all the subsets, it also induces proper direction or inducing of memory B cells and plasma cells. And we know this, we heard this morning, these plasma cells sometimes, in particular, when they have been induced by viruses, there's example here, measles, can have 3,000, 10,000 years of half-life time. At the same time, and we do not know where most of these memory B cells are residing, but possibly they are recirculating, trafficking as a kind of police through the body. We have memory B cells, also very long-lasting, and the elegant work by Klaus Rajewski goes back to this, that they can even survive without the proper stimulation or engaging with the antigen. But they are really very important for during reactivation and then being able to adapt the specificity of the antibodies. And we are not sure to which extent we might be better, let's say, direct this compartment in order to be also able to go for new variants of concerns. But coming back to rheumatological patients, and I showed you here in neutralizing antibodies, and this is coming from our own vaccine study from our department, but it's really reflecting also data from other clinics and so on. But we are able to dissect our treatment armamentarium in at least 3 different categories. The first one, mainly comprising anti-cytokine treatments. This comes really, or came as a surprise to me, that are so effective in controlling disease activity. They are almost not impairing the immune response. There's an intermediate category. Most of them are anti-metabolites, in particular methotrexate, MMF, and so on. They are reducing the neutralizing capacity, but we are having a third, and most of them are the anti-CD20 B-cell therapeutics, but also the direct anti-co-stimulatory molecules, abatacept, belatacept, able to really hamper substantially the induction of the protective antibodies if you take the neutralizing antibodies and the S1 IgG antibodies. What we have also learned, and step by step, based on patient counseling, are doing, when we have the ability to switch therapy, that we are trying to give the patient or switch from the more, let's say, higher risk treatment into a presumably lower risk condition if the patient is agreeable and if this alternative is a possibility. So we have a switch option in those situations. But somehow, and I think you mentioned this already, a lot is recovery of old stuff, but there are tons of data that methotrexate is able to impair tetanus immune responses. This has also been demonstrated by the group of Georg Schett in Erlangen together with the New York group. You see, compared to controls, patients with rheumatic diseases, they have per se a slightly reduced immune response against the vaccine. But if the patients are having, in addition, methotrexate on board, then they have an even further reduced vaccine response, which goes simply back to the classical pharmacology. Methotrexate as an antimetabolite impairs proliferation not only by B cells, but also by T cells. And I think this makes sense. Last but not least, and I think our group then did a lot of stuff on studying in more detail, what is the effect of an anti-CD20 therapy? And compared to what you could do on preclinical grounds, either you knock in or you knock out, we looked into patients who received anti-CD20 therapy and followed them over certain periods of time. And we saw also different shades of repopulating B cells after they received this monoclonal antibody therapy. And a very interesting and a surprise to us observation was that patients who had at least 10 peripheral B cells per microliter available up in or prior B cell depletion therapy with rituximab, they were able to mount an antibody response or even a neutralizing antibody response against the vaccine. This almost never, with one exception, was seen in patients running with below 10 B cells per microliter. And there was the closest correlation with the availability of naive B cells, and we heard something similar for T cells this morning, I think from Petra Bacher. There was also a very interesting correlation between the peripheral B cells and the level of the induced vaccine antibody for IgG and neutralizing antibody. And to be very honest, we have not seen something like this, an interdependence between the compartments of B cells, in particular naive B cells, memory B cells, and the induced antibodies for tetanus, for diphtheria, and for KLH studies that we did before. You might be interested what is with the T cells. We also studied CD4, CD8 T cells, and the only observation was that the CD4, so based on Alex Sheffold's technology, we went also for CD40 ligand, CD137, and interferon gamma producing T cells. In the patients who mounted an antibody response against the vaccine, they had also a T cell response. And what we think that the proper T cell instruction depends also on the availability of B cells. So this is not only a T helper function for B cells, we have also a B helper function for proper, let's say, or propagating T cell responses, at least under these vaccine conditions. We went then in a different, together with Eva Schretzenmeier, who is working in our group, and she also went on, established a lot of antigen-specific B cells. We did not use the tetramer technology like Ugo Schahin is using. We used simply labeled antigen and go for antigen-specific naive and memory B cells, and this works quite well. So we studied patients with kidney transplantation and dialysis patients. And somehow I follow a little bit what Christine Falk said this morning after lung transplantation. And the first study was after the first BioNTech and second BioNTech vaccination. In the meantime, we did the third vaccination with the heterologous vaccine. Most of them received AstraZeneca. So those patients are under calcineurin inhibitors, but also under mycophenolate, either MMF or mycophenolate acid. So therefore, we have a substantially impairment not only on the T cell side, but also on the B cell side, including that mycophenolate impacts on the plasma cells. With a surprise, patients with kidney transplants did not mount any response. The only red dot you see here, this is a subclinical, so far not identified prior infection in a patient after kidney transplantation. The dialysis patients had also substantially impaired anti-S1 as well as neutralizing antibodies compared to a control group. This is very consistent to a larger cohort from the UK. They reported 39,000 solid organ transplant patients, so including kidney transplant patients. And what you are seeing here on the right-hand side, this is a compelling Kaplan-Meier survival curve. We are talking now about outcome and death in this highly vulnerable population. Here you see the vaccinated patients, and here you see the unvaccinated control group. And the difference is here only 20%. So and most of them, 90% have been fully vaccinated, but only twice. But this double vaccination was not really a huge game changer, at least from my perspective. And this is most likely impairment of T cell as well as B cell vaccine responses. So the odds ratio is 0.8, 20% difference. So Eva, and together with Clemens Budde, who are running the kidney transplant unit at the Charité, went on after they have seen, even after the third vaccination with the heterologous vaccination strategy, to the ethical committee of the Charité, and they were asking, maybe we can transiently hold mycophenolate acid in order to go for a successful response to a fourth vaccination, here in particular with the BioNTech vaccine. And with some surprise, and really, I was really surprised that those are patients who continued with the calcineurin inhibitors, and it really turned out to be very safe in terms of the transplant conditions. They mounted after the fourth vaccination in 76% in COV2 IgG response, and in 84% of those patients, they induced neutralizing antibodies. The only non-responders, and this goes back again to the scheme, the non-responders received belatacept, which is a CTLA-4 Ig antagonist, and therefore it explains that TB interaction apparently is further impaired in those non-responders, not allowing to mount a proper vaccine response. You may ask, what's about the antigen-specific T cells? And you can see even after the third vaccination, they had a proper T cell CD4 response in terms of the responders, but also in terms of the frequency of the antigen-specific CD4 cells. This did not further increase with the fourth vaccination. The major game changer, or the gain of the response, was here seen for the B cell or the plasma cell Ig or neutralizing antibody response. So what can we do in our patients coming back now into rheumatology, and in our situations, if switch of therapy is not an option? Similar like in this preprint, what we are doing now, we pause for about 10 to 14 days methotrexate. We have similar data like published here for rheumatoid arthritis patients, that then during the transient hold of methotrexate, we can mount a proper antibody response against the vaccine. What we are also doing in terms of the anti-CD20 treatment, we are using rituximab. Colleagues in neurology, they are treating multiple sclerosis patients with other CD20 molecules, ocrelizumab and ofatumumab. We simply wait for a window of opportunity, and we are really guiding our decision based on the peripheral B cell availability. Again, 10 B cells per microliter, this is 10% for the usual absolute normal number of B cells, appears to be sufficient that we are able to mount a proper response against the vaccine. The last year provided us with a huge possibility to gain insight in terms of the response related to treatment based on the SARS-CoV-2, mainly based on the mRNA vaccine, that we can fill our knowledge about how the treatment, how we can modulate the treatment in order to induce in our patient a proper vaccine response. The other data available so far are for tetanus, but the largest, now most robust database, this is and becomes more and more available for SARS-CoV-2. And I think this is really, hopefully also a luxury to expand this and extrapolate this knowledge to other strategies. So let me come back to my summary and conclusion. In terms of the risk stratification, what we really have seen, that the risk profiles for poor outcome are very similar for the infection and vaccination profiles. The vaccines so far appear to be safe. We have not seen substantial increases of flares or abnormalities or differences in the adverse event rates. At least for the efficacy, we have some correlates with the IgG and memory lymphocytes, what we can use as biomarkers. We have further segregated or differentiate our patients in different, let's say, groups of risk profiles, starting with inflammatory rheumatic diseases, dialysis patients, and then solid organ transplant patients. I think this all goes into the sum of integral of the acquired immunosenescence for the individual patient with the underlying disease. And last but not least, I think this is the major achievement, somehow to some extent unexpected, but we are now able to separate at least 3, possibly 4 different categories of our treatment modalities with different risk of impairment of vaccine responses. And for the risk mitigation strategies, we can go here for personalized treatment, either switch or transiently put therapy on hold. We have biomarkers available, and I think we even can test biomarkers for their validity. And hopefully, and this is the issue, what I have shown you is mainly, let's say, guided by experiences during the Delta period. We have no clue how this might be different with new variants of concern, and in particular with the Omicron situation. But we are step by step also incorporating passive monoclonal antibody usage, and here in particular incorporating second generation antibodies. There are case reports, but we are becoming more and more, let's say, in a situation to incorporate this also in our, let's say, strategies to protect our patients. And hopefully at some time point, we will have available antivirals also for our vulnerable patients. And with that, I would like to thank all of members in our group at the DRFZ and the very fruitful collaboration with a lot of other clinics and institutes, but in particular with the colleagues in nephrology, especially Eva Schretzenmeier and Clemens Budde. Thank you so much.
Thank you so much, Thomas, for pointing our attention to this group of most vulnerable persons in this pandemic. So I'm sure we have questions. Can we not yet? Stefan, please wait a second. I cannot see actually who has raised their hand. Was it Christine? Was it you? Did you raise your hand?
I forgot to raise the hand, but Christian is first. So Christian has the hand up.
Okay. So, I was a bit disoriented in a moment.
Yeah, very nice. Thomas, I'm just wondering, do you have any clinical experience with rituximab treated and successfully with response to the T-cell response vaccinated patients and potential infections then?
Actually, I can only tell you that we had one patient in the kidney transplant cohort who died during the course of our vaccination, and with a clinically almost unremarkable, no cytokine storm, nothing. Apparently everything was suppressed, but this patient died. And we had another in the, what I did not show here, in the rheumatoid arthritis cohort, who got, even after the second shot in a 6 months period, a kind of a corona infection, a Delta subtype, but also from the clinical points, not very remarkable. But in the rheumatology community, rituximab is a red flag. It's only if you don't have any alternatives available, then we go on with this. And this is largely only restricted to patients with ANCA vasculitis, where we don't have any alternative.
Okay, great, thanks.
Christine.
Along that line, and also a little bit to Christian Bogdan's question, in the lung transplant field, there are now more than 20 patients, and Jens Gottlieb is getting the clinical data together, who have been vaccinated, no measurable antibody responses even without rituximab. So 60% of the lung transplant recipients do not have any antibodies against spike. And so they've been treated in the beginning and the Delta phase with the two Delta recognizing Regeneron antibody combinations, and then since December with sotrovimab due to the Omicron sort of change in the viral infection variant. And they are doing quite well. And so the recommendation in the heart and lung transplant field is actually exactly that at the moment, sotrovimab is the only one that is the antibody of choice, and that the passive immunization is the way out for that scenario. And Martina Seester has some kidney recipients who were then infected, and she proposes that then she could measure the T-cell responses, and the kidneys are probably doing better because the T-cell responses are then able to limit the infection. So again, the transplant recipients are really, really the group of concern. And I wanted to ask Thomas whether you would say that there should be sort of more, how should I say that, awareness for this vulnerable group, because sort of it's their intrinsic medication that gives them the higher risk. Question is, how would we deal with that also in public? Because I think this is just underestimated. It's like, you know, it's just a small patient group compared to others, but I think they should deserve more recognition also in terms of protection of this vulnerable group. I don't know what you think. That's a question.
I'm absolutely with you. Maybe it would be good to have for this vulnerable group a kind of overarching small half-page recommendation what to do to have this, let's say, somehow harmonized, but maybe we still lack some evidence, but maybe at the time, or starting with a kind of registry. But I think it would be rather better to have a kind of overarching consensus that that all the transplant centers go along the same line. And I'm completely with you. I spent 1 or 2 hours convincing one patient who was infected, but he wanted to stay at home. He did not want to go to the hospital to receive within the first 2 days the appropriate monoclonal antibody. So this is then sometimes our scientific thinking meets clinical reality, that are patients not willing to come.